Hi and welcome to the latest ECIST podcast. My name's Natalie Rixon. I'm the Urgent Emergency Care Programme Director at Blackpool, and I'm delighted to be here with Chris and Charlotte, who are part of the transfer of care team, who will introduce themselves now.
Hi everyone, my name's Chris Broadbent. I'm the Associate Director of Operations and Head of Hospital Discharge here at Blackpool Teaching Hospitals.
Hi, I'm Charlotte Howard. I'm Hospital Discharge Lead for Blackpool Teaching Hospitals.
Our first question to cover today is, can you tell us about the Transfer of Care Hub at Blackpool?
So the Transfer of Care team at Blackpool is a team of health and social care professionals that work in an integrated manner to coordinate and facilitate hospital discharges for patients that might need some initial or additional support and or services following on from their hospital admission. So as I say, it's integrated. We've got health and social care professionals, and it's about that holistic assessment of what a patient might need to be discharged back out into the community.
How did we get there, Charlotte? What steps did you take as a team to build this really comprehensive system approach to discharge?
Yeah, so our discharge transformation journey started back in 2019, and it was part of when we were planning for winter. We got some feedback from the staff in the hospital that knew there were lots of services out there in community that could support patients following on from their hospital stay, but they weren't sure which team did what, who they should refer to for which service. There was quite a lot of confusion, and it meant that there were unnecessary delays for our patients in leaving hospital. We had a health discharge team and we had social discharge teams, and we're supported by two local authorities here in Blackpool. We have Blackpool Council and we have Lancashire County Council. So there were lots of different systems, lots of different referral processes, and there was quite a lot of duplication. So we wanted to simplify everything, and we implemented a single point of discharge service, which was one team for ward staff to refer into for that expert knowledge and that expert team to be able to support patients with discharge. So we had really good buy-in with all of our key stakeholders. So we all had the same mission, the same goals, the same vision of it being a really streamlined process for our patients on their hospital to home transition. So we did lots of workshops and we got people involved at all levels to introduce this concept because it was quite a new way of working. And it was really important to make sure that we were combining both the health and social care message and really reiterating the patient's voice throughout this.
So what are the key drivers of a functioning transfer of care team?
Okay, so just backing up on what Charlotte notified us before on around that, looking at that holistic review, having that single point of discharge. On my arrival here at Blackpool, what we did notice, and me and Charlotte worked together straight away over the when I first joined, there was teams spread out across the place-based system. So we had single point of discharge, which was Charlotte's team, which she's notified you around. We also had teams in the hospital. We had teams out in community, all trying to do the same job, but all in different ways of working. So the first thing we did, and what was key to driving an established transfer of care services, was co-location. So we co-located all the services together. We integrated, so all the pathways, all the agreements, all the SOPs, the discharge policy was written as an integration rather than silos. So we got our partners together. We identified who's the lead parties for each section and organisation. So we don't have them and us. So local authorities work with us as a team. We're all co-located in the acute trust. We can provide support not just to health staff, we can provide support to local authority, third sector. So it's really an integrated pathway really for discharge planning. What happened then was staff on the wards realised that actually we've got one version of the truth, one version, one pathway, one process to follow, because we're all co-located and integrated as a health and social team. The drivers to making sure it works is our own relationships. Let's take the blame out of this. Have one version of the truth. Now, most people will tell you in discharge, it's one of the most complex things to do. It's easy to admit, it's easy to treat, but it's one of the hardest things to discharge because it's like spaghetti junction. There's that many exit strategies to discharge planning. Because we all work together in the acute trust together, we can work together and have the same output, but in a more timely and controlled manner. So that goes on to the reporting. One version of the truth, one list of patients that are not meeting criteria to reside, rather than social having a list of patients who they're dealing with, health and third sector. So we have one version of the truth, and that list and that reporting mechanism again was jointly put together by our leads within the transfer of care services. We meet on a regular basis, we work day in, day out, we meet every day to discuss as a management team. What helps with that, again, I go back to it, co-location. A lot of organisations and place-based partners and other organisations across the country went off-site due to the COVID. I felt it important when we started coming out of COVID is to come back on site and make sure we've got that on-site presence, because even though it is a discharge to assess model and we are fully discharged to assess, there's always occasions where we may have to see the patients on the hospital site, and we're all together. The reporting aspect of it is, and I've said this for years, even when we go back to detox. So I've done many presentations on detox. Nothing's really changed. We're now calling it no criteria to reside. But what we need to be mindful of when we're reporting this, and this also takes the blame out of it as well, we can't just report the percentage of patients that are not meeting criteria to reside as a single figure. We must report alongside that how long those patients have been delayed once that medic has deemed that patient to not meet criteria to reside, because we want a good number of patients on our no criteria to reside list, but we want them on there in a less time, so the length of stay must be low, and that shows some productivity. If we don't have the fuel, we can't light the fire. And I keep saying to people, we need that list to be healthy, then we can make sure we can move those patients along. And just on that as well, with the reporting which I mentioned, and Charlotte obviously is going to give you guys one of our dashboards and show you what we do and what we report. We evidence on a daily basis and on a monthly basis our performance against each pathway of discharge to assess. We monitor the numbers. We monitor how long the people are on average staying on that pathway to being discharged out of hospital. And just to give some feedback on that, when we first started, for a pathway 1 discharge, and Charlotte will agree with me, we had patients waiting up to 7 days for a package of care to start, and up to 14 days and beyond waiting for placements. Now we're an established team. Now we work together on a daily basis. Now we have that one version of the truth report, and we've got some really good services here. Again, I'm more than happy to share our services and our structure. We're down to same day discharges for home first pathway 1s. We're down to same day discharges for rehabilitation, and we're at around about 3 days for a placement, for a discharge to assess placement. And I think you'll agree that's some significant work that we've done, and really a good achievement that we've really achieved here at Blackpool. And it's not about health leading on discharge. It is that integration and that working together what has helped our transfer of care services to really shine. And I'm very proud of the team, and the staff are so committed. The other thing around this as well is morale. Okay, discharges is very complex. We're always blamed for all the performance issues across the site and the bed blocking, which you hear regularly. But actually, the team have there's a real good morale here. And anybody can come and have a look at the transfer of care services and the hub we've got at BTH. But for me, coming to BTH, I had a vision. Charlotte came along the road, and she was when she first met me, thought I was a bit crazy, because they all did. They didn't think it would be doable. But actually, Charlotte, it is doable, and we work really closely with our partners across BTH and the Fylde Coast.
Yeah,
that's
absolutely.
fantastic.
I think you mentioned one of the key challenges, Chris, about the co-location and bringing everybody together. One of the other challenges we faced was IT systems.
Yeah.
So we've got 3 organisations trying to work together. We've got the Trust, we've got 2 different local authority councils, and we're using a number of IT systems, paper recording mechanisms. And what we did was we made a partnership with an IT firm that built us a health informatics system that we can all access.
Yeah.
So we're now able to receive our referrals on one system from the wards direct. There's a interdisciplinary triage then to allocate someone to a discharge pathway. That's all on the same system, so we can information share, we can document all of our clinical reasoning really, really clearly, and that then becomes a trusted assessment that goes on to the onward discharge service. So if it's Home First, which is our biggest discharge outlet, all of that information then goes as the referral. So we're all working on one IT system, and communication is much, much clearer now.
I think there's something about respect, how well you all work together and how you treat each other. I don't know how we can bring that out further. Is there anything around the role of the discharge facilitators, that they're doing that education and coaching and encouraging strength-based from a ward?
You picked up on a good point. For me, we should be inundated with discharge facilitators, and every ward should have a dedicated discharge facilitator. It isn't, even though we are doing discharge to assess, it's still important to do that baseline information check on admission, make sure we get the concerns from the patients and the families, any concerns they may have, or any really powerful information that we can start to record on Charlotte's system, which you mentioned, which anybody can see. And then when them patients are coming up to being discharged, the DF, the discharge facilitators, which we call them the Red Army, as they're all in red here at Black BTH, they're out there, source that information, that powerful information, and it's recorded on admission. So when we come to doing the triage, and that dedicated triage which Charlotte's alluded to, that actually we're one step further because we've got that powerful information. The DFs also provide education not just to staff and to doctors, medics, and any other and social services. They also provide that support to the families to inform them, this is the process, this is what's going to be followed. And again, part of this, I'll provide the link. We also have a discharge leaflet that was designed specifically for the discharge DFs to hand out, which notifies the families and patients of what our processes are and what the expectations will be once you don't meet criteria to reside, and actually understand that terminology. What does it mean when you don't meet criteria to reside? Because it's quite a frightening, sentence. So the DFs are key to that. They are an integral part to the MDT on the wards, and they do attend the MDTs, and they will check and challenge anybody and any patient that has been deemed not meeting criteria to reside, but clinically ongoing. We get that a lot. So they'll challenge that and say, well, actually, we need to work together. How do we, what are we waiting for? Why is the patient still residing in hospital? So the key to that. The other part you mentioned around what we do as a transfer of care services, we don't just deal with pathways 1s, 2s and 3. And again, that's the national pathways. Our team are vital, and the DFs are vital, and that MDTs are vital to prevent people becoming pathway 1s, 2s and 3s in the first place. Let's prevent them become needing intervention, because a lot of these patients have already been known out in community, already have services out in community, and we do get involved in those pathway zeros. We also get involved in the homeless. We also get involved in housing, outer boroughs. Our team is a central point for any type of discharge, and it's everybody's responsibility.
So can you tell us about your daily processes?
Yeah, so referrals come into the transfer care hub, and they're jointly triaged by both a health and social care professional. So we've got nurses, OTs, physios that work alongside our social care colleagues. Patients are aligned to a discharge pathway, the most appropriate to meet their needs. And if they can't go initially, same day discharge, we have calls every day where we run through all the patients that are waiting discharge, and we collaboratively work through how we can expedite these discharges and get our patients home as soon as possible. In the morning, the teams will run through all of the new referrals, and they'll allocate out to the most appropriate person to triage. And that's done in a collaborative and an integrated way with our social care colleagues.
Thank you. Chris?
Yeah, and just to add to that, what we've noticed as well here at Blackpool is we trust our staff, we trust that MDT, and I say this respectfully, it's less interference from senior management teams getting involved, not giving the power to the people on the shop floor has been absolute success here at Blackpool. We've allowed them to make the decisions. We haven't pressurised that MDT working, and again, pressure can provide division and blame. So actually let the staff be trusted, that trusted assessor, and that's what we've got here at Blackpool, and what works extremely well.
What's next for the team? You've had such great success. What's your plans for the future?
So I'll not talk all the way through it because I know my deputy there is a key to this. The next step is to grow. So in 2 years, we've got a structure, but we've kept it at the limits that we can meet the demand currently. We know our demand is going up. So the next steps for the transfer of care services is one, we need to increase our workforce to meet the demand that's coming through our doors. And two, we need to now focus on quality. So as you all know, discharge planning, a lot of the discharges and a lot of complaints that come back on any incidents that come is around the quality aspect of the physical discharge from the hospital. And again, yes, it's ward level discharges when we're doing the physical discharge, but transfer of care services have a responsibility to support our wards as an MDT. So where our next focus will be on quality and monitoring quality aspects. I'll give you an example of that. One of our outlets and our largest outlet out of hospital is Home First. The issues with the Home First is it's same day discharge. So our medication, our TTOs, our discharge letters always delay. So we're going to work more with the wards regarding that. But also, for example, in June, 200 discharges went via our Home First team, and 97% of those patients remained at home and didn't return back to hospital or to a rehab centre. So we want to progress that. We believe that Home First is our key service for discharge planning. It's a true discharge to assess. Home First, we take the patient, we provide them a slot, the MDT take them home to their own home and provide that assessment. Charlotte, would you agree with that?
Yeah, absolutely. And I think we just want to build on what we've already achieved. You know, before we implemented the Transfer of Care Hub, when we looked at the data, 30% of all referrals into discharge services were deemed as inappropriate because it was either the wrong service or the wrong person that they'd refer to. That's now less than 2% because we've combined all of the resources and we're trying to make it that there's no wrong door for patients. Refer into us and we will support with getting that discharge right. And I think getting the feedback from the patients is really, really powerful. And that's something that we want to continue building on.
Fantastic. The results you've shared are truly superb, and you should be really proud of yourselves and the teams that you lead, and fantastic for sharing that with the ECIST team today. We'll draw the session to a close. There will be a follow-up video, I understand, with some further detail, and we'll also share some links to the information that can be shared, the leaflet you mentioned, Chris, and some of the data packs I think might be quite helpful to share as well. But thank you both so much.
Thank you.